No, it's hopefully a better. Actually, they've stolen all my slides. Actually, they've given most of them, but what I want to talk about is really this is CO2 removal from the ED to the ICU, and really why I said earlier that we're really bringing perfusionists back into the ICU. And the reason is because is the mechanical ventilator becoming obsolete? And I really think it is, and for a lot of reasons. Why am I up here? I consider myself an expert only because what Niels Bohr said, if you made every mistake possible in a narrow field, you're an expert. I've made them all. So I'm an expert. But also what Bernard Hayes once said was, you know, advances are made by answering questions, but discoveries are made by questioning answers. And our answer in the ICU world, and I'm an intensivist, has always been the ventilator. And what do? We make different modes. We change rates. We do this level, that level. We study. But what are we doing? Everything we're doing in the ventilator is to manipulate the blood, right? We put someone on a ventilator, we check their O2 sat. We put someone on a ventilator, we get a blood gas, check their pH, their CO2. We use the ventilator to manipulate the blood. That's what we do all the time. In respiratory failure, what do? Well, first thing we do is we put in this tube that bypasses every possible defense mechanism you could have to prevent an infection of your lung. And then we put you on one of these that blows air into a lung that is designed to receive air. We generate breaths by breathing. Our diaphragms expand. We generate a negative pleural pressure. We suck air in. What do? We designed a platform that blows air into a lung that's designed to suck air in. And what have we done with that? Everything we have ever measured about a ventilator has shown harm. We've never seen a safe ventilator. We do it better, we do it safer, but none of it is safe. So what do? We have someone come in, even if it's non-invasive ventilation, we blow air in. Why? To manipulate the blood, right? That's what we do. So what do? Have someone come in respiratory failure, we evaluate a response. How do we evaluate it? Check their O2 sat. That's a blood measurement. We get a blood gas. Whether it's venous or arterial, doesn't matter. We do that. Why? Check their pH, check their CO2. We're using the lung to manipulate the blood. And then we'll put them on non-invasive. What do? We wait. We check the blood. And so everything we do, we evaluate a response, we look at work of breathing, but most importantly, what do? We check the blood. You check the sat, you check the pH, you check the CO2 in the blood. What I'm here to argue is, why don't we just manipulate the blood and take the ventilator out of it? So if we look at hypercapnic respiratory failure, and this is what CO2 removal is about, we used to say, well, the CO2 climbs, so what? So it goes up a little bit, but the pH is normal, so what? Well, we know now that there is pH-independent CO2 signaling. It actually has, not only does it cause impaired cell membrane, but it's actually an innate immunity suppressant for reasons we don't understand. But it's fairly well documented, and of course it has some cellular wall energy function, but most importantly, it enhances vasoconstriction, it increases arterial pressure, but most importantly, and what we're finding more and more, is the RV discoupling. And remember, you do well in the ICU based on your right heart, not your left heart. Cardiologists don't really know that there's a right heart, but the right heart is really, in the ICU, is what really changes the difference. The ones that survive preserve their right heart. The ones that die don't. And it becomes actually that clear. So CO2 removal becomes, I think, very, very important. And so mechanical ventilation, we use the lungs to manipulate the blood, but there comes a cost. And if you're on a ventilator for 2 or 3 days and you're healthy, say you overdosed or you just got too much anesthetic, you're probably going to be okay. If you have ARDS or other lung injury and I put you on a ventilator, I'm always going to cause harm. So there's always going to be a cost of mechanical ventilation. And so what we're trying to do with extracorporeal CO2 removal is say, if the problem is that the pH is low and the CO2 is high, let's just manipulate the blood, not manipulate the lungs to manipulate the blood. Let's just manipulate the blood, because that's really where the rubber meets the road. And so we can do that and allow the lung to heal, and we do it extracorporeally, as all y'all know. But this has kind of been what we're used to. They're on a ventilator, and they're on ECMO, and they're sick, and they're sedated. And we use this as a salvage procedure, right? They were so sick, they were so bad ARDS, I had to put them on ECMO. What we're trying to do is bring that ECMO to the front and say, let's do that at the start. Why are we waiting until these patients deteriorate so badly that now it becomes a salvage procedure? Let's use this as a preemptive procedure. There's a guy playing on his iPad getting ECMO early, and you have to do it early. Up and ambulating. As Dr. Bartlett said, they should be extubated, ambulating, and walking on ECMO. Here's a patient of ours, wanted to go to the solarium on ECMO. She could eat, she could talk, she could do physical therapy. And the reason is we decided to manipulate the blood, not manipulate the lungs to manipulate the blood. And this is why I think perfusionists are coming back into the ICU, is because we're now manipulating the blood and not the lungs. And so it requires a rethinking. And again, ECCO R or ECMO, all of that, we're really fixing the blood directly, not using the lungs as intermediary. And we're allowed to do no harm with a ventilator. Let's take a case example. This is a 5-year-old, came in with an asthma attack. He was seen in the emergency room, came back 30 minutes later, pH was 6.8. Only a kid could survive that, right? PCO2 was 188, but the pulmonary dynamics were so bad that once he was intubated in the emergency room, of course, immediately, paralyzed, it took him 15 seconds to exhale. So there's no way I could give a rate greater than 4. Well, what did they do? They gave him a rate of 24, so he got hyperdynamic inflation very quickly. And what people don't realize about asthma, when you do those kind of pressures, asthma becomes a heart problem then, because the right heart starts to fail. And that's what happened to this child. And what we're going to do is kill him. I mean, severe hyperdynamic inflation. So we're not smart enough to do other things, so we put him on ECCO R and extubate him, took him off the ventilator. So, we're going to kill him with the ventilator, so let's just take him off. This is him immediately after cannulation. You can see he's on nasal cannula just because we could. He really didn't need it, but we felt we should. And you can see this is curve. PCO2 in less than an hour normalized, and pH normalized. No ventilator. In fact, he didn't breathe at all. We actually had a sweep so high, he didn't need to breathe anymore. This is him on the left, 34 hours after cannulation. We were able to decannulate him after he got his mag, steroids, and everything. In the middle is an hour after he's drinking a Coke. And then all the way to the side is 6 hours later, he's eating a hamburger. You do that with a ventilator? How many days would that kid be on? Days and days and days just to get over the sedation, not just get over the ventilator. I presented this at that class that Bill talked about. He's a little terrorist. He had a mouth you would not believe. I should have intubated him just to shut him up because, I mean, seriously, after this hamburger, he asked the nurse, says, "Where's my ice cream, bitch?" No kidding. 5 years old. So I should intubate him just for, I don't know, some lesson or something. But it did teach us a good lesson is that, we manipulated the blood. We didn't manipulate the lungs to manipulate the blood. We manipulated the blood primarily. And this is why I think I talk at this conference is because perfusionists are coming back into the ICU because we're bringing this into the ICU and the ventilators are going to become a thing of the past. And everything is going to become extracorporeal, I think, unless you're overdosed or something very temporary. But if you're prolonged in either situation, I think the ventilator is a thing of the past. Here's a young lady, COPD, severe bronchospasm. Again, right heart dysfunction, put her on a ventilator. She wasn't doing well. Put her on an arterial CO2 removal device, which previous speakers have talked about. Extubated her. She could talk. She could eat. She could do physical therapy. And within a few days, as you can see me talking to her, she didn't cuss me out. The little kid did, but she was actually grateful. You could see that we just manipulated the blood. We didn't try to manipulate the lungs to manipulate the blood. We manipulated the blood primarily and let the lungs do what they wanted to do. And we treated them. As you can see, she's getting her breathing treatment. We treated the bronchospasm, and she got better, but we did not have to put her on a ventilator for days and days and days. Sedate her, which we know the ventilator is harmful. We know sedation is harmful. And we know the longer you get either of those, it's harmful. And so we just took that out of the equation. This is an arterial CO2 removal device. This is a pumpless, off-the-shelf. That's an affinity oxygenator from Medtronics. This is actually, we think, the first kid that's ever gotten this. This was a few years ago for asthma. Again, took him off the ventilator completely. And could eat, could talk, could cry, could cuss. This kid didn't, but again, and you can see, it takes us 15 minutes to put it in at bedside. I mean, we can do it that quick. So it takes actually less time to put them on this than it actually does to get a ventilator set up, ready, intubated, sedated, all of those things. We can get this in at about the same time. This is a commercial device, the Novolung, which you saw earlier, but it's the same concept. But I think this is the future. And the future is, and we're part of the VOID trial, which several speakers have talked about, but this is a CO2 removal device that uses a 15.5 French cannula. Not much bigger than dialysis cannula. Not much bigger than a trauma line. And we're putting this in, and we can get about 65 to 70% CO2 removal. And the trial we're doing is in COPD, but you can see that this is going to go beyond that. And it is that when they come in, they don't get intubated. They may get on non-invasive, but then they get to this device. They go on extracorporeal support and no longer a ventilator. So ventilator becomes a secondary thought. So instead of, I'm going to put them on ventilator, if they don't respond, I'm going to put them on ECMO, we're trying to reverse that. Say, I'm going to put them on extracorporeal support, and I'm going to manipulate. And if I can't do that, maybe I'll need to manipulate the lungs to help. But for the most part, extracorporeal therapy is revolving around. And what Dr. Bartley said, is all these things are coming around, and CO2 removal is its third or fourth iteration. We're getting smarter, we're getting better, the technology is getting better. We're not heparinizing, we're using DTIs more acutely, even in children. We're just getting smarter at doing it. So the risks that were always there, and the people that always taught you these great risks of ECMO and extracorporeal support are disappearing rapidly. And we have to start thinking that ECMO is not as a salvage, it's not as a last resort, that's the first intervention. And that's where I think we're headed in this new millennium of extracorporeal support. So for hypercapnic failure, I think mechanical ventilation is becoming obsolete. I think it's becoming obsolete very quickly. And I think it's going to be followed closely by ECMO support for hypoxic respiratory failure. I think it's probably going to be CO2 and then that. But after all, what do we want to do? All of this is fix the blood. So why not just fix the blood? Why go through the lung? Just fix the blood. And that's what we're trying to do. And that was it. Try to get through quick so we can make it on time.